and in fifth month, and it mother is a known case of pregnancy induced hypertension since 25 weeks, and was on tablet labetalol. Mother is also a known case of GDM, and is on insulin. No history of bleeding or leaking PV. In third trimester, mother received 2 doses of injection betamethasone, 24 hours apart, and last dose was received on 6th of July. Mother also received loading and maintenance dose of magnesium sulfate. Natal history. Baby is a male baby with a birth weight of 940 grams, born via emergency LSCS in view of impending eclampsia on 9th of July at 3 a.m. Baby was born limp with no spontaneous respiratory efforts and bradycardia. Baby received PPV for 2 minutes, after which baby had spontaneous respiratory efforts and heart rate was improved. Initial ABGAS scores were 3 and 7 at 1 and 5 minutes. Baby was then shifted to NICU and was given 2 doses of surfactant 6 hours apart. And baby is on ventilator support currently. And that is history. So.
Dr. Sanmita, so this is an acute case you are presenting, right? So,
Yes.
um, okay. So, what are the most important aspects in the antepartum history that you would be interested with respect to this particular baby?
If mother has received steroid coverage, um, magnesium sulfate, any history of PPROM, any antibiotic if mother has received.
Mhm.
Um,
And immediate postpartum?
Immediate postpart baby wise, so,
Yeah.
what resuscitation baby has received, if baby has received any surfactant. Um,
Anything related to the placental transfusion strategies? So, this baby did not cry immediately after birth, right?
yes, sir.
So, is there any option of doing deferred cord clamping or
No, immediate cord clamping has to be done in this case.
what about cord milking?
It should not be done. So,
Why?
um, there are chances of like
Yeah.
a baby is not stable,
Yeah.
and
What are you, I mean, really worried about considering the gestational age of this baby?
polycythemia, IVH.
Yeah, IVH, yes, severe IVH.
Yes, sir.
Hmm. So you're going to demonstrate there?
Sorry, sir.
You're going to demonstrate the baby, right? Because it's a
Yes,
cute
yes,
case.
sir. Yes, sir.
Okay, you can start with the examination. Is there anyone to help you out, or how is it?
Yes, sir. Our sisters are there. I'll ask.
Okay, okay, you can switch on your video.
Oh, 1 second. శ్రీ వీడియో పట్టుకోవా కాసేపు. Light on channel.
Try to do your presentation, restart your presentation fast because we don't have much time.
Yes. Phototherapy option. Babies.
Don't disturb the baby. You can present from there.
Sorry, sir. Don't.
Don't disturb the baby. You can present from there.
Okay, sir.
Yeah,
So babies currently is being nursed in incubator with a set temperature of 36.7 degrees Celsius and measured temperature of 36.9 degrees Celsius. Baby is lying in supine position with a cap, ET tube of size 3, fixed at 6.5 centimeters, sir, and NG tube fixed at 14 centimeters, 5 French NG tube. UVC and UAC lines are placed, and temperature probe is fixed on the abdomen, and pulse oximeter on the right foot.
Anything else related to the incubator that you want to comment on? 16 hours of life, postnatal age.
The humidity is at 85%.
What is your unit protocol regarding the use of
We
incubator?
start at 85 to 90%, sir, and every day we decrease by 5%.
Preterm units of all gestational age.
Between less than 32 weeks.
So this is a double-walled incubator or a single-walled incubator?
Double-walled incubators.
So what is the mechanism by which the temperature or the thermal homeostasis is maintained in a incubator compared to a radiant warmer?
Convection and evaporation.
It will prevent evaporative heat loss through what mechanism?
Humidification.
Okay. And what about radiative heat loss? Why are these incubators double walled? What is there in between these two panels?
Prevents the.
So you will have heated air in between them, right? So
Yes.
it prevents the radiation.
Yes.
Okay. Anything else specific to the position of the head and the bassinet in relation to this baby?
Yes, the head position is to the right lateral because of the ventilator fixation.
What would be the ideal position?
Central.
Okay. And would you is the head end elevated?
Yes, sir, it is elevated.
Okay. What is the purpose of doing these two, especially in the initial days of life?
To prevent the blood flow fluctuations to the brain.
Outcome wise, to prevent
IVs.
Okay. Carry on.
Vitals, the heart rate is 148 beats per minute with limits between 90 to 100. And respiratory rate is 58 cycles per minute with a good chest rise. The color of the baby is pink, and CRT is less than 3 seconds. Measured axillary temperature is 36.8 degrees Celsius and saturation of 93 percentile with FiO2 of 21%. And weight of the baby is 940 grams, which is more than 10th centile. Length of the baby is 34 centimeters, which is more than 50th centile and less than 90th centile. And head circumference is 26 centimeters, which is between 50th and 90th centile.
How did you measure the length of the baby who is sick?
Currently, we just took segmental tape methods.
not that important. Anthropometry is not important in a sick baby. Okay. So, what you said, the peripheral oxygen saturation is 93% with a.
Yes. With an FiO2 of 21%.
Let's try to avoid acronyms. Can you say a fraction of inspired oxygen and things like that? No?
Oh, okay.
So you're happy with the saturation? What is the normal? What is the saturation target that you would be?
If it is in room air, we expect more than 95%.
Okay, in this baby, what is the?
88 to 95.
Okay. Are you aware of the neoprom
No, no.
analysis?
Um, if the fractional inspiratory oxygen is more than 25, then the higher limit of saturation will be between 90 and 95. If it
So,
is
what is the what does the different academic do the different academic societies recommend uh, with respect to oxygen saturation targets? You can tell either of them, the American one or the European, or even our National Neutral Forums, CPG. 88 to 93, do you think that's okay? You want to
90 to 95.
okay 90 to 94 or 91 to 95? So there are two different recommendations. With a saturation of 90 through 93, can you predict the PaO2 of this baby?
Yes, sir. It is PaO2.
Yeah, PaO2. Can you predict it? Okay, what is the PaO2 that you would that would be okay for this baby?
Um, eh, More than 60, sir. Between
Do you
60
have a
to
range? Okay, I'll go and read about that and carry on. Yes, what about the principles behind the working of a pulse oximeter or a multipara monitor with respect to measuring the peripheral oxygen saturation? What is the physics behind that?
uh, it should be pre-ductal.
What's the physics behind? Do you have any uh,
Sorry, sir.
laws? You have laws, right?
Yes, sir. Sorry, sir, I don't remember.
Okay. So maybe you could read Beer Lambert's photoplethysmography. Okay. What is the PCO2, partial pressure of carbon dioxide, that you would target in this baby? A baby who is 16 hours of age, postnatal age, and
Yes,
ventilated.
uh, between 40 to 50, sir.
Okay. You're basing your answer upon any particular trial? Is there a role for permissive hypercapnia in this baby?
Not in the initial 48 hours.
Good. Okay, carry on.
Um, Coming to the general examination, the anterior fontanelle is open and is at level. The posterior fontanelle size is normal. The size and shape of the skull are normal. No caput succedaneum or cephal hematoma. No birth injury to the skull. Eyes are normal. There is no evidence of cataract or subconjunctival hemorrhage. Ears are at normal level. uh, no facial dysmorphism. The skin is plethoric, no neurocutaneous markers. Umbilicus has UAC and UVC placed. Genitals, according to the Ballard score, it is 0. And anal orifice is present and no pedal edema present. And peripheral sinus. That is. And systemic examination. Babies on conventional ventilator.
Can you tell about the ventilation aspect, the settings in the ventilator and
Yes,
yeah,
sir.
thanks for that.
Baby is on PCAC mode, sir, with a volume guarantee mode. With a VG of 5 ml per kg, PEEP of 6, a maximum pressure of 21, rate of 40, and inspiratory time of 0.3, and FI at fractional inspiratory oxygen of 21%. And water level in the chamber is below the level, sir, with humidifier temperature of 37 degrees Celsius. And
So we'll start with the humidifier. That 37 degrees Celsius, that is the proximal temperature that is proximal to the baby, or that is the distal temperature.
This is the distal temperature.
Can you show me the distal and proximal temperature?
The humidifier.
Yeah, it's showing 37. Can you show me the proximal and distal? Just press the mute button in that humidifier, no? Long press.
Yes.
Long press. Yes. That is the distal temperature and that is the proximal temperature.
Yes.
Where is the proximal temperature sensor placed? Inside the incubator or is it outside?
It is inside the incubator.
Are you okay with that?
No.
What can happen if you place the? It's outside the.
It's outside the incubators.
Yeah. So what is the purpose of that limb? Proximal to the proximal temperature sensor.
Sorry, sir.
Why have you placed the sensor outside the incubator?
So that it does not get manipulated with the incubator temperature.
What if you place it inside? What will happen? Okay. You told something. Okay. So that might falsely indicate a higher temperature.
Higher temperature.
And that is a servo controlled.
Servo control.
So there will be a chance that you will have excessive rain out in the inspiratory limb. Okay. Does your expiratory limb have a heating wire?
Yes, sir.
Is it required? Because in bubble CPAP systems, we have seen that we don't have a heating wire for the expiratory limb.
Yes.
Why do you need a heating wire for the expiratory limb when you are using the ventilator? For invasive ventilation or for even for delivering non-invasive ventilation? Why, what is the
For the humidification and heated gases.
Yeah, that is for the inspirated limb. For the expiratory limb. So raining out in the expiratory limb is not good, right? If the water goes into the incubator, into the ventilator, your ventilator might get
Yes.
oiled.
Condensation.
Yes. So to prevent the to actually safeguard your ventilator. Can you show the screen now? I mean, yeah. So what is this assist PCAC?
Assist control mode, sir. Pressure control, assist control mode.
Pressure controlled?
Assist control.
And you are targeting the volume also.
Volume, yes.
So is it a volume controlled ventilation or is it something else?
We are delivering the measured volume at the particular pressures.
Okay. So what is this called?
Volume guarantee.
Okay. What is it? It's a hybrid mode of ventilation. It's basically a pressure controlled ventilation with volume targeting. So you have different names. It will depend upon the ventilator. Okay. And can you show me the PV loop? pressure volume loop. So we don't have enough time, so okay. What is your interpretation?
To deliver a volume of 5 ml per kg, um, 11 of PIP is required.
So what would be the first thing that you would be looking at when you see the pulmonary graphics or a loop?
How much volume is being delivered?
First thing
At
is
what
at the
pressure?
scale, right? Scale. So in the y-axis, until what volume have you set? Y-axis, what is the maximum volume?
Maximum volume is 21, sir.
So that is something that is quite high, right? For a
Yes, yes.
first thing is you have to adjust your scale. Then only you can interpret these loops properly. Okay.
Yes.
So this baby you're giving 5 ml per kg, something like that will be approximately 4.5 to 5, I guess.
Yes, sir. 4.7.
And if you keep a scale of 20, you might not be able to interpret the loops properly. Okay. What all you can see in this? I mean, how are these, how is this helpful interpreting the PV loop in a baby with respiratory distress syndrome in the initial hours of life? You're given
Like if the adequate volume is being delivered to the lungs or not, and how much pressure is required to deliver that amount of volume.
that is depicted in numbers also, right? In your in the
Yes, if there is any blocks also.
Can you do you know what is the opening pressure, the closing pressure? What is C20 by 20? There is a compliance in the last, I mean, 20% of the lung divided by the total compliance. Have you read the pulmonary graphics?
Yes, sir, but I don't know.
Yeah, go and read.
Yes.
What is beaking?
Sir?
What is beaking? You can detect.
Okay.
You can detect the response to surfactant and so on and so forth. Okay. Then coming to uh, the temperature, the important aspect in this baby. So, what is Hayes thermoneutral zone? Can you define it?
Uh, at what air temperature the baby is able to maintain the normal level of body temperature?
With minimal metabolic.
Uh, uh, Expenditure.
Okay. What is zero flux concept? Where do you fix the probe? You fix the probe in the abdomen, right?
Abdomen, sir.
So, is that
Or
okay?
on the shoulder also we can fix.
Usually, the back, I mean, the lower flanks would be an appropriate place because zero flux says there should not be any room for the surrounding air to go
Uh,
through the temperature sensor. Okay. Um, Apart from that, so what all are the other things that you think you could do for this baby um, that could
um,
improve the outcomes as of now? As of now, you are showing the baby right now, right? The baby is uh,
yes. Uh, we should try to wean off the ventilators, sir, since the baby is 28 plus weeks.
anything related to developmentally supportive care. First thing is you could elevate the head. You could keep the head in midline.
Yes.
The length of the tube is length of the tube also, I think it's quite long.
Long, so it should be 2 to 3 centimeters.
Yes. It's good that the temperature sensor is outside. So the head should be in midline.
Midline.
And nesting you could do, right? In this baby, that would make
Yes.
baby more comfortable. The baby is in a frog-like position. And
Yes.
of course, you had covered the.
Nesting is there, but it is
Okay.
large for the babies.
Okay. Okay, fine. Anything else you want to add?
About the care, we can start early nutrition. So,
Because we don't have that much time to discuss everything. So we just discuss some aspects of how an incubator works, the humidifier, something about pulmonary graphics. Okay. So there are other things as well. Because of paucity of time, we'll stop here. Okay.
Thank you, Dr. Veer, and thank you, Dr. Samhita, for that clear presentation. And thank you, Dr. Veer Raghavan, for bringing in so many important aspects as a part of the discussion. So I will now request Dr. Megha to begin her presentation from Ernakulam Medical Center. So, Dr.
Yes,
Megha,
ma'am.
I hope you're ready. Please, ensure your video is on, and kindly arrange your, person who is helping you with displaying the baby to be, present next to the baby, so that we don't waste much time in the process.
Yes, ma'am.
Thank you.
Shall I start, ma'am?
Yeah, sure. Please begin.
So I'm presenting baby A, 5 days old, singleton male baby, born at 35 weeks plus 5 days gestation, with a birth weight of 630 grams by emergency LSCS, indication being previous LSCS in labor with scar tenderness. Baby was admitted in our NICU with respiratory distress and was on CPAP support. Currently, baby is postnatal age of 5 days with postmenstrual age of 36 weeks plus 3 days of CPAP support and establishing feeds. Coming to antenatal history, baby is born to a 33-year-old G2P1L1 mother with previous pregnancy being term AGA with birth weight of 3.1 kg, which was via due to LSCS due to failed trial of labor. Currently, child is 5 years and is a healthy baby. Present pregnancy, it was spontaneous conception to a non-consanguineous marriage. They have married since 6 years. Mother's blood group is O positive. She is a booked case from 12 weeks of gestation in our hospital. Coming to the first trimester, pregnancy was diagnosed by UPT at 1 month of amenorrhea and was confirmed by antenatal sonography at 6 weeks of gestation at a local hospital. LMP was on 27th of October 2024 and EDD is 3rd August 2025. NT scan done at 12 weeks was normal. There was no history of any fever with rash, bleeding PV or any other history. Coming to second trimester, iron and calcium supplements were started. 2 doses of Tdap were taken at 16 and 20 weeks of gestation. Quickening was felt at 19 weeks of gestation. GTT was done at 25 weeks of gestation, and the mother was detected to have gestational diabetes, and was started on oral hypoglycemic agents, metformin, 500 mg BD. Anomaly scan done at 20 weeks was normal. Coming to third trimester, she will continue to take iron and calcium tablets, continued on OHA for gestational diabetes. Growth scan done at 28 weeks plus 2 days was normal. There is total weight gain during pregnancy was 11 kgs. Fetal movements was perceived well. There was no history of any pregnancy-induced hypertension. At 35 weeks plus 4 days, mother developed intermittent abdominal pain for which she was admitted to the labor room. Blood investigations done were normal. CTG was reassuring, and there was no history of any fever or leaking PV or bleeding PV. On examination, mother had scar tenderness for which she was posted for emergency LSAs. Our team was informed regarding the same, and we had given a brief antenatal counseling. Baby was born via emergency LSAs due to previous LSAs in labor with scar tenderness at 11:13 a.m. on 4th July 2025 with birth weight of 2,630 grams. Baby cried immediately at birth, but thereafter went into heart rate less than 100, for which PPV was initiated with TP's resuscitator with PIP of 21 and PEEP of 6, after which heart rate had improved to more than 100. Respiratory efforts had also improved, and saturation recorded was to be 80. Upper at 1 minute was 5, 5 minutes was 6, and 10 minutes was 7. Course in NICU. Baby was shifted to NICU on CPAP support with TP's resuscitator. Baby was admitted in NICU and placed under radiant warmer and connected to CPAP with FiO2 60% and PEEP of 6 centimeter of water. Admission temperature was 36.7. Baby had a Silverman-Anderson score of 5, and baby had tachypnea with upper chest and lower chest retractions, audible grunt, and nasal flaring. Initial stabilization was done as per unit protocol, and baby was kept NPO and started on IV fluids at 80 ml per kg per day with GIR of 6 mg per kg per minute. Sepsis screen done was negative. Blood culture
Okay,
and
Megha.
sensitivity.
Megha,
Sorry, sir.
so this is an infant of diabetic mother.
Yes, sir.
Antenatal history. So you told oral glucose tolerance test. Can you please tell me the specific cutoffs to diagnose GDM?
Fasting needs to be more than or equal to 92.
Needs to
One,
be, I mean, to diagnose a mother with gestational diabetes mellitus, you have different guidelines from various organizations. Can you tell me any of them? WHO one, ACOG, RCOG, or FOXY?
fasting blood sugar should be more than 126.
Good. And
And 2 hours should be more than or equal to 200.
are you sure? This is what World Health Organization's criteria, or no, you're giving this glucose load, right? Oral glucose. So how
Yes,
many
sir.
grams do you give? If you don't know, go and read. It's okay, fine. Yeah,
Sir, 75 gram
yeah,
OGT.
yeah. 75 gram, 2 hours. It is more than 40.
More than 140. More than or equal to 140.
Anything else you would be checking in this mother? Because OGTT, we usually do it between 24 to 28 weeks, right?
Yes, sir.
So anything, I mean, many of these mothers, someone has written 200, even I forgot 126, I'm sure. Postprandial, I mean, after the glucose challenge, you have to see what is the cutoff. HbA1c, yes, someone has answered it, HbA1c. What is the utility of HbA1c in this mother? So we are not sure, right? The prevalence of diabetes is quite high in the Indian population. So
Yes, sir.
I think our FOXY, the FOXY guidelines tailored to Indian context says that in the first visit itself, we have to do a random blood sugar because we might miss type 2 diabetes mellitus. So HbA1c would provide a rough idea about the glycemic control in the past 3 months, I guess. And it is very important in the first trimester because of the risk of malformations. What are the malformations that you can expect in a mother with type 2 diabetes mellitus and whose glycemic control is poor?
Um, there could be cardiac anomalies. Babies will be
Cardiac, then
cardiac anomalies such as TG and VSD.
yeah,
Then
other systems.
Neural tube defects.
Hmm.
Caudal regression.
The incidence of caudal regression is very less. It is quite specific to, I mean, mothers with poorly controlled diabetes mellitus, but it's a rare occurrence. Then renal, GIT.
Renal agenesis.
What about cardiac hypertrophy?
Asymmetric septal hypertrophy.
Does it happen in the first trimester? It usually happens in mothers with gestational diabetes mellitus, not the ones with type 2 diabetes mellitus. It can happen in mothers with type 2 diabetes mellitus also. It happens usually at the end of the second trimester, after 28 weeks. Okay. Which particular organ will not undergo hypertrophy? And how is it clinically relevant? Usually they are macrosomic, right? Infants of diabetic mothers. Can you name one organ that is not sensitive to hyperinsulinemia? Someone has written the answer in the chat box. The brain, fetal brain. So, what does it result in? So the head size will be disproportionately low compared to the shoulder width. It can result in
apparent microcephaly.
And the clinical consequence?
Shoulder dystocia.
Okay, fine. And then you talked about TP, I mean, providing resuscitated with the TPS resuscitator.
Yes, sir.
What is the role of delivery room CPAP in late preterm and term babies? Late preterm and term babies. Do we have enough evidence to? Okay, that's fine. So there is a risk of significantly increased risk of pneumothorax. Okay, I think the audience, they are well-read people. So already they have answered it. So a large cohort study with 8,000 late preterm and term infants, which had evaluated 8,000 plus infants, have shown that there is an increased risk of pneumothorax. So we are still unclear about the utility of delivery room CPAP in this bigger cohort of babies. Then what else did you tell? Okay, you carry on.
So the ABG done initially was showing respiratory acidosis, and chest X-ray done showed bilateral hazy lung field with blurring of diaphragm and heart border, which was suggestive of grade 3 of respiratory distress syndrome. After
Megha, the first thing you told was the blood gas. That was a capillary or venous or arterial blood gas?
Arterial blood.
Okay. So what is the difference between acidosis and acidemia? So the better terminology could have been respiratory acidemia. Okay, you could read it from Nelson. Please go and read the difference between acidemia and acidosis. So whenever you interpret a blood gas, the final pH value, if it is in the acidemic range, you should tell it acidemia. The components might be acidosis. It might be metabolic acidosis with respiratory alkalosis. Okay, so that someone has commented it. Good. Then next.
It's chest X-rays.
Yes. So how do you grade RDS?
It is from grade 1 to 4, sir. Grade 1 is usually having a reticulogranular pattern. Grade 2 is showing aerobronchogram, and grade 3 is by bilateral hazy lung showing blurring of diaphragm and heart borders, and fourth is whiteout lungs.
Okay. So why is it important in RDS? Say, for example, you have a chest X-ray of a baby with meconium aspiration syndrome. Why specifically they have graded the chest X-ray in RDS, in neonates with RDS? Do you have a grading system for meconium aspiration syndrome or congenital pneumonia based on the chest X-ray? Does it correlate with the clinical severity? A baby with a bad chest X-ray, I mean, with a grade 4 RDS, would the clinical symptoms be severe, or
Yes, it will be severe, sir.
what about the other pathologies that we talked about? Transient tachypnea, meconium aspiration syndrome. Does it correlate with clinical severity?
TTNB,
Usually, meconium aspiration syndrome and other lung pathologies, the chest X-ray may or may not correlate with the clinical severity. But in case of respiratory distress syndrome, it does. That's why they had a grading system. Are there any other diagnostic tools that you could use to classify the severity of respiratory distress syndrome? Apart from, yeah, someone has written,
ultrasound.
yeah, lung ultrasound. Hmm. Okay. Then, you told, yeah, carry on. You came up to 60% or 0.6 FiO2.
After which a single dose of surfactant was administered at 2 hours of life via Ensure technique. And gradually CPAP settings were weaned off and baby was depronged by 70 hours of life. Thereafter, the baby was stable in room air. Baby was hemodynamically stable with normal heart rate and BP. Enteral feeds were started on day 2 of life and gradually graded up as per tolerance and has now reached 19 ml of feeds, which baby is tolerating. And baby has passed urine and meconium in 24 hours. Today, baby is 5 days old with corrected gestational age of 36 weeks plus 3 days with a weight of 2.58 kilograms and head circumference of 33 and length of 49. Baby is stable in room air and is on OG feeds. Baby is receiving a total fluid of 180 ml per kg per day. And EBM is being given, and calories come up to 229, and fats come up to 9.12 grams, and proteins come up to 3.42 grams. Coming to the summary, it is a late preterm, 35 weeks plus 5 days, male baby, appropriate for gestational age, with a weight of 206.30 grams of birth weight by emergency LSCS, with RDS, required CPAP support, and received 1 dose of surfactant, who is now stable in room air, and OG feeds are being tolerated well.
So, is there a role of surfactant in late preterm and term babies? Is there a role of surfactant? The traditional concept is that after 34 weeks, the surfactant pool in the lungs are good enough to keep the alveoli expanded, right? Are you aware of any large ongoing trials? Yes, someone has answered yes.
Uh,
So there is a large trial that is ongoing, the SURF-ON trial. Okay. So RDS does occur in late preterm and term babies. What is the National Neonatal Forum's clinical practice guideline criteria for surfactant administration in late preterm and term babies? With relation to the CPAP?
They don't, it is usually recommended for babies less than 34 weeks, sir.
No, even for late preterm and term, NNF CPG has come out with recommendations, right? Have you gone through that? If you have not, do read it. It's available freely as an app. The previous recommendations and the latest ones are available in the website. So more than 34 weeks, the CPG says you may consider surfactant when the CPAP level exceeds 7 centimeter or more, or if the FiO2 requirement is more than 40%. And what surfactant did you use for in this baby?
The
What type of
NeoSurf, sir.
Okay, what is NeoSurf? Is it a bovine lung extract or a bovine lung minced or a porcine lung minced or a?
It is a bovine, sir.
You sure?
Yes.
Someone has written carfactant. Don't know for what.
Surfactant alpha, sir.
Read about the different types of surfactant. Okay. Then, what type of CPAP was used in this baby?
Simple CPAP, sir. Bubble CPAP.
Bubble CPAP. So, what are the types of CPAP you know of?
Bubble CPAP and the CPAP via ventilator, sir.
Okay. So, they have what kind of a flow? Variable flow, constant flow. So, you have CPAP systems with constant flow, right? Constant flow of gas,
Yes, sir.
which you just indicated. Ventilator delivered CPAP and bubble CPAP. What about variable flow CPAP? There is something called variable flow CPAP as well, which works on some principles, Bernoulli principle, Quanda principle, and all. You should be aware of it because many units do practice that as well. Okay, fine. I think we are reaching, okay, there's still 9 minutes more. So final diagnosis.
Sir, a fine diagnosis, it's a late preterm baby. Late preterm baby with appropriate for gestational age and a weight of 200-630 grams. It was diagnosed to have RDS and received 1 dose of surfactant.
What are the 6 components that you always mention in the diagnosis? 6 aspects. We start singleton or twin. Then, so this is a singleton baby, right?
Yes, sir.
Second one, it was late preterm. 35 weeks, right?
Yes, sir.
Third, birth weight. What is the birth weight?
2,630 grams, sir.
Birth weight. Then you told appropriate for gestational age. Then fifth, gender. What is the gender?
It's a male baby, sir.
And born via lower
Emergency NSCs.
C-section. Then you comes your diagnosis. Respiratory distress syndrome.
Received 1 dose of surfactant.
No, that won't come in your diagnosis. So, what disease pathology did the baby have, or the pathologies did the baby have? So RDS, BPD. The
RDS, sir.
that you have done will not come in the diagnosis. Can you tell the diagnosis now in that order?
Sir, it's a singleton male baby with who's appropriate for gestational age. It is a late preterm, it's 35 weeks plus 5 days, with birth weight of 2,630 grams. The diagnosis of RDS.
Born through what segments is it? If
Born
you
through,
get that order, then you will not forget it.
yes, sir.
Okay. Anything else you want to tell about this baby? So blood sugars were okay.
Yes, sir.
So what is the significance of intrapartum blood glucose levels in the mother with relation to the blood sugar values in the baby immediately after birth? The first aspect we talked was HbA1c, right? In the first trimester
Yes, sir.
can have a bearing on the fetus. What about the intrapartum blood sugar levels or blood glucose concentration in the mother? Can you predict anything from that with relation to baby's blood sugar values? Yeah, chances of hypoglycemia are high. So can you tell me the clinical course of an infant of diabetic mother with hypoglycemia compared with the IUGR or a growth restricted neonate with the hypoglycemia? Is there any difference between the clinical course of these two babies, these two sets of babies with respect to hypoglycemia? When do you think it will resolve? I mean, why are the infant of diabetic mothers prone for hypoglycemia?
Because of insulin levels, hyperinsulinemia will be there in the baby.
When do you think that will get resolved? So it's usually
Once the maternal sub maternal effect subsides by 2 to 3 days.
so usually it gets resolved by 12 to 24 hours. Okay, in IDM babies, whereas in growth restricted babies, they have other issues like decreased glycogen storage, decreased brown fat, and so on and so forth. So the etiopathogenesis of hypoglycemia is very different. So they might even have hyperinsulinism that can last for weeks. That's why we usually monitor infant of diabetic mothers for a maximum duration of up to 24 hours after birth. We monitor the growth restricted ones for up to even 72 hours because the risk of hypoglycemia is there for a prolonged period of time after birth in growth restricted babies. I hope you could understand what I'm trying to tell. And, did you look for injuries in this baby?
Sorry, sir.
Megha, did you look for any birth injuries in this baby?
There
Birth injuries.
weren't any birth injuries, sir.
So, what are the birth injuries that you could expect in an infant of diabetic mother, even if the baby is born through C-section?
If it was a normal delivery, we would have suspected shoulder dystocia, so brachial plexus injury.
So, it does not happen with C-section? It does happen. So, that's why they do not suggest C-sections or LSCS for infant of diabetic mother until and unless the weight of the baby is more than 4,500 grams estimated fetal weight. Okay, so even in babies born through C-section, they can have birth injuries if the mother is diabetic. Okay, and I think that should be okay because you presented fast to ask so many questions. Good. You have to read more, I guess, huh?
Thank you, Dr. V. Raghavan and Dr. Megha for that again very interesting case. I think it was like a rapid fire of so many questions, lots of learning for everyone who's listening. Thanks a lot, Dr. V, for taking out your valuable time.
Thank you, madam. Thank you for inviting me.
It was our pleasure. Thank you, Dr. Veer. It's now my pleasure to welcome our second faculty for the day, who is Dr. Abhishek from Ovum Hospitals in Bangalore. Dr. Abhishek, are you there? Can you please switch on your video so that we can all see you?
Good evening, madam. I'm here, madam.
Yeah, thank you, Dr. Abhishek. So, Dr. Abhishek again needs no introduction. It's always a pleasure to interact with him. He's MD and DM from the prestigious PGI MER Chandigarh. Dr. Abhishek has unique interest in a lot of areas, including quality improvement in neonatology, nursing education. He is also one of the very enthusiastic researchers we have today in neonatology, and is into a lot of research, including community-based research. Thank you, Dr. Abhishek, for being a part of FEED today, and we welcome you to take in the next case that is to be presented by, I think, Dr. Mandeep. Are you there, Dr. Mandeep?
Yes, ma'am.
So over to you and to Dr. Abhishek for the third case of the day, and this will be followed by OSCEs. So please stick to time, and you can start your case presentation now.
Thank you, madam, for that kind introduction. Mandeep, you can start with the case.
Good evening, sir.
Good evening.
I am presenting a case of RH negative pregnancy of XYZ baby delivered by an RH negative pregnancy born at 37 plus 6 weeks of gestation to a mother of Gravida 2 para 1 live 1 abortion 0 mother at a birth weight of 3.1 kg through emergency LSCS on 24th of June 2025 at 2 p.m. at a private hospital in Solan, and that was referred to our institute on live day 3 with yellowish discoloration of body and sclera. And within levels of time of admission was 19.53 by day 3, for which double volume exchange transfusion itself was done on day 3. After double volume exchange transfusion, by day 5, baby developed respiratory distress, was hemodynamically stable for 48 hours after double volume exchange transfusion, and was shifted to oxygen for in case of distress, and was diagnosed with early onset neonatal sepsis with culture sensitive suggestive of Enterobacter. By day 9 of life, baby also developed neonatal seizures, for which baby was started with anti-epileptic medications and with also required midas infusion for 2 days and was kept on ventilator mode. And currently baby is on extubated. Currently baby is on oxygen by nasal prongs at 1 liter 21% with a dummy score of 0 and 1. Currently baby is on live day 16 with a gestational age of 40 plus 1 week. Antenatal history, family and maternal history. Mother is an RH negative mother of 32 years with a blood group of AB negative. Father's blood group is AB positive. Mother is a Gravida 2 para 1 with Gravida 1 is a male child of 2.5 years, male child with a blood group of AB positive. Antenatally, mother received NTD post-delivery. After first child. Antenatal history in first trimester, it is a book pregnancy with supervised at a private hospital by Dr. Renu Malan at Solan. It was a spontaneous conception confirmed by UPT. There was no history of any fever, skin rash, or lymphadenopathy, or exposure to any radiation or drug or in the first trimester. First USG was done at 8 week plus 2 days with an ETD of 1 July in 2025. In second trimester, iron and calcium supplementation was started when 1 dose of injection Tdap was given. Quickening was felt at 18 weeks. There is no history of any blurring of vision, no history of any GDM hypertension, no history of any thyroid disorder. In second trimester, second USG 17 weeks was done. That was normal, and Indirect Coombs test was first performed at 17 weeks of gestation. That came negative. In third trimester, there is a history of NTD taken at 28 weeks of gestation with 20 weeks of gestation with 300 microgram IM NTD immunization was given. There is no history of any polyhydramnios and no history of any oligohydramnios. There is no history of any perinatal fever, no history of any leaking per vagina or bleeding per vagina. Baby was delivered natally. Baby was delivered by emergency LSCS in view of previous LSCS with meconium stained liquor with mother developed intermittent abdominal pain at 37 plus 6 weeks of gestation. Baby was delivered by normal LSCS and baby cried immediate after birth with an APGAR score of 8 and 9 at 1 and 5 minutes respectively. Baby postnatally, baby was immediately was stable and shifted to mother's side and was breastfed within 1 hour of life. On day 2 of life, parents noted slight yellowish discoloration of body and sclera, for which relevant investigations were sent, and that came to be total serum bilirubin was 19.53 milligram per deciliter, and direct Coombs test was positive, for which baby was referred to our center for further management. Baby was received at our center at Liver 50 at the time of admission. Baby was hemodynamically and clinically stable, but birth weight was 3.1 kg at the time of admission to our institute. The weight of the baby was 2.830 kg with a weight loss of 8.70%. Baby was clinically hemodynamically stable with no any systemic deficit. Respiratory system was normal. Abdominal findings were normal. CVS findings were normal. CNS findings were normal. There was no hepatosplenomegaly, no caput, no any bleeding, no any bruise, no evidence of any cephalometama. And on examination, and the icterus was found clinically up to Sol. By day 3 of life itself on admission, as the serum bilirubin levels were sent, and that came to be post exchange transfusion range by in a more than 35 weeks of gestation using a Botany score. Botany scale exchange transfusion range came to be 17, and levels of the baby was 18.53, for which exchange transfusion was planned, and double volume exchange transfusion itself at Liver 57 was itself started with O negative blood and AB positive plasma, PRBC and AB positive plasma in 2:1, 2:3, and 1:3 ratio was taken, and double volume exchange transfusion was done. During double volume exchange transfusion, baby had no any adverse effects, and post transfusion, CBC, calcium levels, electrolytes were investigated. For investigation, the bilirubin level came to be 7.3 milligram per deciliter, and on serial monitoring at after 6 hours, the phototherapy was continued, and 11.51 was documented and continuous, and after 12 hours it came to be 10.51. The bind score was at the time of triple volume exchange transfusion was 0. But on day 5 of life, baby developed sudden onset tachypnea, for which baby was shifted to O2 support, and then investigations were done for that revealed rising trend in procalcitonin with falling platelet counts, for which antibiotics were upgraded to vancomycin and miomycin, and LP was done as the previous culture that was sent at time of admission showed a positive growth, but sensitivity was not available. For that, LP was done. On day 7 of life, the culture came positive with Enterobacter sepsis, sensitive to meropenem, antigacycline, and levofloxacin and Pepzo. Baby on day 5 of life, on day 8 of life, and baby was on room air, comfortable, was on him with Downey score of 0. Suddenly develops multiple episodes of desaturations also, and was again shifted to O2 by blender, and FiO2 requirement rise up to 4 liter per minute with 40% of FiO2, and Downey score deteriorated by 3 or 4 by 10. and within next 24 hours, baby developed multiple episodes of seizures. This was after 6 days of double volume exchange transfusion. Baby developed multiple episodes of seizures, for which initially injection phenobarbital loading was given, but seizures continue and another medial loading was given. Seizures continued and injection levetiracetam was added, but seizures did not stop and injection benzodiazepine midazolam was started by 2 mic per kg per minute, but seizures continued to happen and we continue to hike up midazolam up to 8 microgram per kg per minute. Baby was kept on SIMV mode at a setting of PIP of 18 PPO6 with 30% FiO2. Baby responded to injection midaz infusion, and within next 24 hours, within next 48 hours, midaz was gradually tapered and stopped, and baby was extubated after 48 hours. Currently, baby is on live day 16 is on O2 by nasal bronchs and 1 liter 21% with downward score of 0 to 1 and maintaining saturation above between 91 to 95 saturation.
I think, thank you, Mandeep. I think it's quite complicated history. You have entire neonatology there, starting from jaundice, sepsis, so seizures, ventilation, everything. So, couple of quick questions. Can you summarize the history for me?
Sir, it is a singleton full-term 37 plus 6 weeker, appropriate for gestational age, male child with 3.1 kg birth weight, with neonatal jaundice, with RH incompatibility, with double volume exchange transfusion, with early onset culture positive, early onset neonatal sepsis with enterovector cloacae, with neonatal seizures, query bacterial neonatal meningitis, query bilirubin, acute bilirubin encephalopathy.
Okay. See, when you have such a complicated history, I think everyone will agree with me that you started off with the postnatal history, went back to antenatal history, again you came back to postnatal history. So it will be always good either to start with antenatal, go to postnatal, avoid repetition of the postnatal history. Because in your initial 3 minutes, I think you spend a lot of time on the postnatal history. Again, you came back to postnatal history, right? It'll always be good to stick to one particular flow. Let us go back to antenatal history. You said that it is Gravida 2 living 1. What history was essential here in this case of RH isoimmunization?
So in RH immunization, history about either NTD immunization was received or not at initially. By the time of initial first pregnancy, if there is a tendency, if mother is RH negative and father came to be RH positive, we quickly go for indirect comb test. If that came to be negative, we apply an NTD immunization at 28 weeks of gestation with 300 microgram. And if by the time of delivery, if the blood group of baby is also positive, is RH positive, within 72 hours we give another 300 microgram of NTD-RH isoimmunization. So history regarding RH, NTD-RH immunization was taken, and NTD was given after first delivery as the blood group of the baby came to be a positive.
You're absolutely right. You're worried about whether NTD was received in the previous pregnancy, what's the blood group of the husband, and probably ICT status in the current pregnancy. You mentioned that 16 and 28 weeks it was negative and we gave anti-D. One direct question is, you said that anti-D was received in the previous pregnancy, but still in the this pregnancy also we given anti-D. Why do you think the baby ended up developing RH isoimmunization?
Sir, if NTD is given appropriately on time, there is a up to by 90% reduction there is a sensitization risk will reduce. After first to second pregnancy, if there is an isoimmunization, the sensitization is 17% approximately. So the chances of isoimmunization are still there. So baby can develop in progressive pregnancy transfer of antibodies from mother to the baby, and chances of neonatal hyperbilirubinemia is still there.
So you mentioned that anti-D, if you give anti-D, 90% there is protection from not developing RHS immunization, right?
Yes, sir.
So is there a possibility that mother had any missed abortion in between, or is there a possibility that the dose of anti-D what you gave is not sufficient?
Yes, sir. Yes, sir.
So placing my question again, you gave 300 micrograms of anti-D. That will neutralize how much amount of fetal blood? We give 300 microgram to neutralize fetal blood, right? Whatever the fetal blood has entered the mother's plasma, we're trying to neutralize it. So this 300 microgram equates to how much amount of fetal blood? How much fetal blood are we trying to neutralize with 300 microgram?
Sorry, sir.
See, typically literature says that if there is 30 ml of fetal blood or 15 ml of fetal RBCs, we neutralize using 300 microgram. What if the fetal maternal hemorrhage is 45 ml? This 300 microgram may not be sufficient. So I repeat, it is 15 ml of fetal PRBC or 30 ml of whole blood, fetal whole blood. We are trying to neutralize with 300 microgram of anti-D. Clear? So how
Yes,
do we quantify the amount of fetal blood? Are there any tests you are aware of?
Okay.
Somebody is mentioning KB test.
Yeah.
Do you want to break it up? What is this KB test? Can you tell me the full form? Yeah, it's Klehor-Betke test. With Klehor-Betke test, we are able to identify how much amount of fetal-maternal hemorrhages happened, right? Okay. So you mentioned that we have given anti-D. Let us say the baby was born in Solon. Let us assume this baby was born in your setup. How will you monitor this newborn for the first 48 hours?
So initially, if the baby was to be born at our setup, we should have sent the cord CBC and cord bilirubin levels.
Great.
But unfortunately, that were not documented. They were not documented at the previous hospital. Initially, if we would have sent for clinical examination for development of a neonatal jaundice using a Kramer staging with from levels from codocephalic. If there is a rise of serum bilirubin levels of 5 milligram 5 milligram per deciliter per day, we would in first 24 hours we would suspect an positive RH isoimmunization neonatal hyperbilirubinemia, and we would start it for a phototherapy for the baby. If there is a rise in initial 24 hours, there is a rise in serum bilirubin of 0.3 milligram per deciliter per hour. Or if there is after 24 hours there is a rise in serum bilirubin of 0.2 milligram per deciliter per hour, we would have suspected the baby would end up in pathological neonatal hyperbilirubinemia, and we would have we would aggressively manage the case.
Yeah, I got a bit confused with whatever you said. You said that you are going to send cord PCV cord bilirubin, right? At what level would you have started phototherapy? I think we lost Mandeep. Mandeep.
Sorry, sir, the electricity went off.
Yeah, tell me at what cord bilirubin, let us say you have sent cord bilirubin and PCV, at what levels you would have acted?
5 milligram per deciliter, sir. If it is more than 5 milligram per deciliter within first 24 hours. Yes, sir.
What would you do? Let's say the cord bilirubin is 6, cord PCV is 25.
If there is a cord PCV less than 35 or if hemoglobin is less than 10, we would have gone for a PRBC transfusion of 50 ml per kg.
So the bilirubin is 6.
Bilirubin is 6 at within 24 hours.
Yeah, cord value is 6.
We would arrange for total volume exchange transfusion.
You will arrange for exchange and start intensive phototherapy, right?
Yes, sir.
So would you start prophylactic phototherapy if the bilirubin value came as 4?
Yes, sir.
Remember, there is no role of prophylactic phototherapy in neonatology. We only give phototherapy only if the value crosses certain thresholds. I think in your history taking, you were mentioning something called Bhutanese chart, and then you would start phototherapy. Is Bhutanese chart
Bhutanese-
used for pre-discharge to identify the high-risk babies or to decide phototherapy?
For pre-risk babies to decide for phototherapy and exchange transfusions.
Remember, for the fellows out there, Bhutanese nomogram is to identify babies at risk for jaundice. It is used to assess pre-discharge bilirubin threshold before discharge. To identify the risk there before discharge, we use Bhutanese nomogram, while we use something called AAP photo chart, American Academy Phototherapy or Exchange charts, to decide threshold for starting phototherapy or exchange. Some units also use NICE charts. Both are equally good, AAP or NICE charts. We use Bhutanese nomogram only to assess pre-discharge risk factors for development of high risk of jaundice, right? Never use the word Bhutanese nomogram for starting phototherapy, right? Okay. So at 4, there's no role of prophylactic phototherapy. We would start phototherapy at a value of 6. Now the value is 6. It's very close to exchange. When do you want to repeat the bilirubin?
Sir, with the, as
In
I've
other
started,
words, for any baby with jaundice nearing exchange, when will you repeat the next bilirubin after starting phototherapy? If it is close to exchange.
within 2 to 4 hours.
So remember, you need to repeat as early as 4 hours. 2 hours will be too early for the jaundice to reduce. Typically, we repeat it after 4 hours. Remember, after ROP, the next highest legal cases are in jaundice. So fellows out there, you have a safe practice. If it is very close to exchange, repeat it after 4 hours, right? You mentioned a word, we will start intensive phototherapy. What do you mean by the term intensive phototherapy? Is it single surface, double surface, triple surface? What do you understand by the term intensive phototherapy?
In intensive phototherapy, we started with triple surface phototherapy with 2 overhead phototherapy units and one provided from below the cot.
I am not sure whether triple surface exists or not. So can you mention to me based on the intensity of light delivered?
The intensity of light recommended is from 460 to 490, wavelength of 460 to 490 with 30 microwatt per centimeter square per nanometer.
Yeah, you're right. The intensity, the wavelength of phototherapy light must be anywhere between 430 to 460 nanometers. And typically, we expect the light to be more than 30 microwatt per centimeter square per nanometer. You're right. If your double surface is able to deliver, that should be good enough. Unless it is delivering less, you can use one more light add-on on the top. There's no standard term called triple surface. That still many people use it, right? Okay. So we've started phototherapy. We have repeated the value after 4 hours, and we decide to do exchange, right? You mentioned that you did double volume exchange transfusion on day 3, correct?
The baby presented to us on day 3 itself.
Right. Is there a role of fluid relaxation in those cases where it is very close to exchange?
Yes, sir. If there is a range of 2 milligram per deciliter close to exchange transfusion, we can give fluid relaxation that can, with extensive continuation of extensive phototherapy, we can give fluid relaxation to prevent double volume exchange transfusion.
So remember, fluid relaxation has a typical role when you have dehydration, but still many people have studied in the setting of non-immune hemolysis, non-AB or non-RH setting, where they have found that we are able to avoid exchange. But in the case of RH isomerization, if there is a component of weight loss, it may help. The purpose of fluid relaxation is to buy time in arranging blood. So let us say if the value is high, we may end up doing an exchange, not just rely only on fluid relaxation, right? So how will you calculate the blood required to do double volume exchange?
It's at the 160 or 180 ml per kg, required, divided into, if it is an RH incompatibility, we choose for O negative blood, and divided into 2:3, 2:3 and 1:3 ratio, where the 2:3 with PRBC and 1:3 with plasma. O negative PRBC was arranged and AB positive plasma was arranged.
Is it 160 or is it 180?
160 to 180.
Remember, for a baby who is above 2 kg, it will be 80 ml per kilo. So it is 2 into 80 is double volume, 160. Typically for babies below 2 kg or below kilo, it will be somewhere 90 ml per kg. You use some charts to assess the blood volume, right? Are you aware of any such charts? We use in
Rolling chart.
as well, right? Rowling's chart, correct?
Rolling charts.
So we can see Rowling's chart and decide the volume. And some people even add plus 50 ml to adjust for the wastages across the lines, right? Okay. So you did exchange. By doing double volume exchange, how much volume did you intend to clear from the baby's blood? Was it 63%, 80%? Was it 90%?
During double volume extraction, we up to 85%.
Yeah, it's around 85 to 87% you are intending to change the blood there, right? So did you give IVIG?
No, sir.
Is there a role of IVIG in RH incompatibility?
We, if as the DIRCOM test was positive, we could have given the IVIG if there is an after double volume exchange transfusion, the bilirubins almost settled down, and there was no rebound seen. So, and the repeated DCD was positive. So, if we want to give, we can give.
Remember, IVIG we give if you're not able to get appropriate blood. So that's the only reason we may use IVIG for the case of jaundice. The main purpose what people have studied in IVIG is IVIG prevents post-DVT anemias, not jaundice. IVIG will not protect you against jaundice. It primarily protects you against anemia caused due. So if you have not given, that should be fine. But generally we would have given if you're unable to arrange blood. But some units end up giving IVIG, let us say post-DVT if your jaundice is still rising. They may use IVIG after the first exchange transfusion. Some units do use it. The NNF-CPG doesn't recommend IVIG, but AAP says a statement saying that IVIG may be used in cases of AB or RH incompatibility. It says may be used. It doesn't give a strong recommendation there with the available evidence. Okay. So now you said this baby underwent exchange. This baby had deterioration on day 4, again deterioration on day 8, again had seizures. Do you think, is there a possibility of healthcare associated infection?
The baby was diagnosed with the initial blood culture that was sent at the time of admission on before 72 hours of life that came positive with Enterobacter sepsis.
So since your admission culture grew Enterobacter, you're not labeling it as healthcare associated infection? When do you label as infection?
Hospital acquired, if baby would have presented after 72 hours of life and new alterations were again documented, and the repeat culture that would have sent that would have shown any positive growth, we would have suspected for healthcare associated infection.
You're right. After 72 hours, especially if the organism is not incubating at admission, we label as healthcare associated infection. But once you have a device, from there after 48 hours, your audit will start. Typically after 48 hours, after having your device in the form of central line, it would have started. Since your admission culture has grown your Enterobacter, there's less possibility of having healthcare associated infection. So can we move to examination now? Because we've already finished almost nearly 25 minutes in the history. Can we move to examination? Mandeep, can we start examination? Mandeep, please proceed.
The baby is being nursed in a radiant format with a set temperature of 36 plus 6 degrees Celsius. Baby is on a servo mode with the monitors attached with showing an heart rate of 151 and a saturation of 98%. Where the baby is kept on oxygen by out of a blender at 1 liter, 20% FiO2 through a Remsen scanner with an OG tube in C2 and temperature probe from radiant warmer is attached on the right hypopodium. Baby is lying in a supine position with lower limb flex and one left upper arm is extended and right arm is being flexed.
Is the baby on bubble CPAP or plain oxygen?
Sir, is on plain oxygen.
Okay, because there was a Ram's cannula CPAP interface. That's why I asked the question. Okay, you connected the Ram's cannula to a nasal prongs. I'm not sure what's the benefit. Okay, you can do it as per your unit policy. You can proceed actually. Anthropometry of the baby.
The baby is an head circumference of 34 centimeter, recorded from suprasternal waist to suboccipital maximum suboccipital margin with a length of 50 centimeter.
Weight.
Weight is birth weight is 3.1 kg. Now weight of the baby is 3.340 kg.
So it's always good to mention Fenton's chart or WHO charts or mention whether it is normal or abnormal as well. Once you mention anthropometry, okay. I presume they must be normal. Can we proceed to general physical examination?
Yes, sir. Sir, from head to toe. Yeah, sir. So from head to toe, baby has a normal shape of skull with AF at level with no suture overriding and posterior quadrantally is open with permissible of less than 1 centimeter. There is no facial deformity seen. The eyes are the eye seems normal. The nose is central with no facial deviation. The ears are at normal level with no abnormalities in the neck. Chest is symmetrical. This abdominal findings are normal with there is no any bruises or any signs of any trauma to the baby, and there is no any abnormal findings or hypopigmented lesions seen. Umbilicus has been fallen off. Baby is a male child with a normal descendant testes and no granulocytes are normal.
See, whenever you comment about the genitalia, always mention about hernial orifices.
Yes,
Always mention about
the
DDHS.
hernial are normal, sir.
Hernial orifice is normal. Complete with no developmental dysplasia of hip, and never forget spine as well once you mention about your head to toe examination. Okay, can we proceed to CNS examination?
Yes, sir. The initial mental functions currently first with the behavior side. Currently, the baby is in presentable to score with eyes closed and with gross movements were seen. And for first, then we look for the level of alertness in the baby, for which like the arousability in the baby as the baby is in eyes closed or sleep state.
So as per Pritchell's state, what was a maximum state the baby could reach?
Baby cries spontaneously, opens eyes after continuously with requirement of feed.
To the fellows out there, I think the best way to mention the higher mental function is you start with state to state variability. You mentioned that state to state variability is good or poor. You say what is the maximum state that was reached during the course of examination and what was a predominant state. I think you can see in this case state to state variability is, I would say, poor, and the maximum state probably you could reach is state 2 or state 3. Predominant state was state 2, correct?
Yes, sir.
So it is moving from state 1 to state 2. Occasionally state 3, I would say. Predominant state is state 2, right? Okay. What are the other components of higher mental functions in a newborn? Apart from state to state variability?
Includes habituation,
Correct?
consolability,
Correct?
cleanliness,
Correct? No need to show, no need to show. You can name them actually. I don't want the baby to be disturbed. I lost a few of your words. You mentioned state to state variability, habituation, consolability, cuddleability. What else?
habituation, sir.
Yeah, no need to do the baby. Let the baby sleep. You can list them out. Yeah. Can you list the higher mental functions?
So higher mental functions includes behavioral states, level of alertness, habituation, consolability, and cuddliness,
Yeah.
and cry.
You can also look at spontaneous limb movements. You can also look at defense reaction. You can also look at habituation, visual auditory fixation following. So I think that's good to read or list out all the parameters in higher mental functions, unlike the pediatric age group. Okay. I presume cranial nerve examination is normal. How about tone? Can you tell us what was the tone you found during examination, especially the popliteal angle and adductor angle?
Yes, sir. The popliteal angle, sir. Once we expose the baby, remove the diaper.
Okay.
Diaper repeats. Sir. we examine popliteal angle for each limb with initial fixation, and then gently with gentle pressure on heel, we. So there is an IV line on the
Right.
right limb, so
So
I'm performing it on
most important
left
step
limb.
while checking angles in a newborn is we should keep the head in midline. You can always ask
Yes.
your fellow, or you can take help of your nursing officer to keep the head in midline. Otherwise, you can stimulate asymmetric tonic neck reflex, right? So was the Moros normal in this child, or was there a hung up Moro?
Nice. Normal.
Okay. In the history, you mentioned about bind score was 0. Does this baby have bilirubin encephalopathy, or is it because of meningitis?
My score was always scored 0. There was no bilirubin encephalopathy noted. There was no any hypotonia, hypertonia, or abnormality, or decreased feeding was noted. He was is still on full feed and staying well. Uh, it may be because of neonatal meningitis we were suspecting.
What's your final diagnosis?
Sir, it is a single baby full-term AGA LSAS delivered at 37 plus 6 weeks with a birth weight of 3 kg with neonatal hyperbilirubinemia with RH incompatibility with EONS vector sepsis positive with neonatal meningitis and neonatal disease.
Okay, thank you, Mandeep. So I think it's time up now. So I think you presented well and you could demonstrate the science well. Now let us move towards the next section of today's discussion, that is OSCE. I think you can start answering in your chat box. Hope my screen is visible. So is my screen visible? Okay. So you can start answering in the chat box. Can you identify the positions A and B? Yeah, somebody says A is UVC. Okay. Is A UVC? Or B is UVC? I think Anupam has answered both as UVC. Okay, A is UVC, B is UAC. Okay, correct. What should be the ideal position of A and B? So they say UAC should be T6 to T10. UVC should be below diaphragm. UVC to be T10. Any better answers for UVC? Okay, what is the recommended duration for placement of A and B? Yeah, I think somebody has answered right. Navdeep has answered UVC should be at the junction of cavoatrium. Correct. What's the recommended duration of UVC and UAC? Yeah, this is 7 to 10 days, 7 days, 10 to 14 days, 5 to 7 days. Okay, the answers for you. So I think A, all of you answered right. It's UVC, B is UAC. Ideally should be at the junction of IVC and right atrium, cavoatrium junction, T8 to T9. Ideal UAC position is T6 to T9 or even T10. Typical duration of placement as per Clougherty now is UVC 7 to 10 days, UAC is 7 days. I think the recent Clougherty has changed it from 10 to 14 days to 7 to 10 days. UAC they say 7 days. So it is 7 and 7 to 10 days. Okay, let's move to the second question. What is the protein content of term and preterm human milk? What is the protein content of term and preterm human milk? Term 0.9 to 1.1, 1.6 and 1. Okay, most of you are answering right. What are the advantages of starting HMF? Extra calorie, protein and calories is the right answer. What is the concern of adding bovine-based HMF? Concern of adding bovine-based HMF. CMPA, NEC, not sure. CMPA is a possibility. Allergy is a possibility. Okay. What is the typical dose of HMF? 1 gram in 25 ml, correct? So the answer is for you. Term milk contains 1 gram per 100 ml. Preterm milk, we define in the first 21 days as preterm milk. It contains anywhere between 1.4 to 1.5 gram. The purpose of adding HMF is to increase proteins and calories. The concern is there's no long-term benefits in neurodevelopment or growth. Concerns is with protein allergy. Typically, we add 1 gram per 25 ml. Okay. Let's move to the next question. You have a 30-weeker, 1 kilo preterm initiated on CPAP in the delivery room. The baby is shifted to NICU, requires bubble CPAP, PEEP of 5 centimeters, and FiO2 of 30%. How do we assess respiratory distress severity in preterms clinically? Okay, most of you have answered SAS score, right? What's the advantage of delivery room CPAP? Advantage of delivery room CPAP, yeah, FRC. What clinical outcome does it convert into? Decrease the need for surfactant, reduce the need for mechanical ventilation, right? When should we administer surfactant? I think Veera covered in the last case, in late preterms. When do you consider surfactant in this 30-weeker 1 kilo? At what CPAP level? Yeah, PEEP more than 6, FiO2 more than 30. What are the indications of surfactant other than RDS? So remember, 40% FiO2 is for late preterms. For less than 34 weeks, the threshold as per European consensus is PEEP more than 6, FiO2 more than 30%. Yeah, what are the indications of surfactant other than RDS? It's mass, severe pneumonia, pulmonary hemorrhage, right? How do you define timing of early rescue surfactant? As earlier than 2 hours. Yeah, most of you have answered that. Answers for you. You can use either Silverman-Anderson score or Downey score. So using delivery room surfactant, you can prevent surfactant requirement or intubation in nearly 50%. PEEP more than 6, FiO2 more than 30%. We also use an idiopathic PPH in surfactant, apart from pneumonia, mass, and pulmonary hemorrhage. Early rescue is as early as within 2 hours. Okay, let's move to the next question. A 3 kg baby is born by vaginal delivery, had meconium stained liquor. The baby was limp at birth, required intubation. In NICU at 1 hour, the baby is on SIMV mode, pressures of 22/5, MAP of 10, 40 rates, 100% FiO2. The baby's SpO2 is just 90%. Here's a blood gas for you. ABG shows pH of 7.18, PaO2 40, PCO2 60, bicarbonate is 22, base excess of -9. How do you want to interpret this blood gas? Is it respiratory acidosis? What about the metabolic component? Yeah, somebody says it's mixed. Is it mixed respiratory acidosis and metabolic acidosis? Yeah, it's mixed acidosis. You're right. So what should have been the expected bicarb here? What should have been the expected bicarb? Yeah, it's uncompensated. Bicarb should have been more or less. Bicarb should have been more. How much? What is the compensation for acute respiratory acidosis? It's 1 per 10 or 1 to 2 per 10. Should have been ideally 24 plus 4, right? Ideally near 28. Okay. Can you calculate OI for this case? OI, oxygenation index. Yeah, 25 is the right answer. What is the formula for OI? Yeah, it's map into FiO2 by PaO2. You answered right. What is the OSI in this case? OSI is a relatively new term that has come in. Your answer is right, 11. What's the formula? Remember, it is saturation instead of PaO2. It's map into FiO2 by SpO2. You have not done a blood gas. You have map, you have FiO2. You can look at the saturation, right? I'll skip AADO2 for short of time. At what OI will you consider inhaled nitric oxide for PPHN? At what OI will you consider inhaled nitric oxide for PPHN? It's typically 20. Yeah, most of you have answered right. At 20, you consider nitric oxide. Most of you have answered correct. Okay. Coming to the question number 5. There are two main types of growth chart, reference and standard growth chart. Give one example for reference growth chart. Reference growth chart. Yeah, Fenton's, Ehrenkrantz, they're all reference growth chart. Okay, give an example for standard growth chart. Remember, WHO is a standard growth chart. It is not a reference growth chart. So basically, reference chart tells you how the child grows, while standard growth chart tells you the ideal way, how the child should grow. And WHO is one of the standard growth charts where they've used healthy population and tried to generate healthy curves there. A reference chart, basically, they've clubbed all the available data and made a chart. Okay. Fenton's chart joins WHO MGR's chart by how many weeks? Okay, 50 weeks. When does WHO intrauterine growth chart joins the MGRS charts? When does WHO intergrowth charts joins the WHO MGRS charts? I know Fenton's chart joined by 50. You've answered right. When does the intergrowth chart joins the WHO MGRS chart? It's typically by 64 weeks. What is one concern or disadvantage of using WHO intergrowth chart in the unit? What is one concern or disadvantage of using WHO intergrowth chart in your study? They have taken postnatal EOGR into consideration. Not agree, Divya. Okay. Any other concern? So Anupam is partly right. So less than 33 weeks, the data available with WHO intergrowth chart is very less. Less than 500 data is available. And the problem with WHO intergrowth chart is it overestimates IUGR, underestimates EUGR. It makes more IUGR babies in your hospital. Define EUGR. Define EUGR. Yeah, it's less than 10 centile at discharge or at 36 weeks. What is the expected OFC gain in preterms? What is the expected OFC gain in preterms? 0.7 to 1 centimeter, you're right. I think most of you have answered right. Okay. Let's move to question number 6. I think we have discussed in the case today. 3 kg baby born to mother with A negative blood group. Baby's blood group is O positive. Baby is third in the birth order. Noticed to have bilirubin of 18 and 24 hours. You have decided to start intensive phototherapy and arrange blood. What flux level determines intensive phototherapy? I think we have discussed in the case. What flux level determines intensive phototherapy? It's more than 30 microwatt per centimeter square per nanometer. What is the preferred blood for DVT in this case? 20 is less Sagarika, it must be above 30. It's O negative PRBC, right? Or A negative. It is either A negative or O negative suspended in AB positive plasma. The preferred choice will be the mother's blood group, A negative. Okay, what is the antibiotic of choice for exchange transfusion? You're doing an exchange or procedure. What should be the antibiotic of choice? Remember, antibiotics are not recommended just because you have done an exchange. Most of you are right. No antibiotics is the right answer. What is the amount of blood replaced by single and double volume exchange transfusion? Amount of blood replaced in percentage? Yeah, it's 63 and 87. Okay. What is cold heart syndrome? What is cold heart syndrome? Yeah, basically it is related to cold blood and high potassium levels. It can actually cause arrhythmia and cardiac arrest. So since the blood is stored, the potassium levels will be very high in the blood what you do exchange. So you have to be very cautious. That's why while doing double volume exchange, we typically connect the baby to ECG to look at the rhythm. And some of the units use blood warmers for doing exchange transfusion. Right. Okay. So you have a 38-weeker meconium aspiration on SIMV mode. It's on volume guarantee mode with 20/5 pressures, 40 rates, 60% FaO2. Based on the PV loop, what needs to be optimized? What parameter in the ventilator needs to be optimized? Yeah, there is beaking. You need to decrease PEP is the right answer. Which graphic helps to optimize inspiratory time? Which graphic helps to optimize inspiratory time? Yeah, flow time scaler. What is the optimum tidal volume to be targeted during invasive ventilation? Yeah, it is 4 to 6 ml per kg. Divya and Mitali, it is 4 to 6. 4 to 6. Which graphic is used to assess compliance of the lung? Which graphic? Remember, it is PV loop, not flow volume loop. PV loop. Name a ventilation strategy employed in case if you have air trapping. If you have air trapping, what ventilation strategy will you employ? Increase TE, okay, right answer. Increase PEEP, right. What will you do for rates? PSP may not be the right answer. What will you do for the rates? Increase the rate is a wrong answer. Anushka, if you increase the rate, you may end up decreasing the TE. If expected time is decreased, air trapping will increase. You need to decrease the rate. Right. So I think most of you have answered it. So if you have air trapping, decrease the rates, decrease IE ratio, and increase PEEP. Okay. You have a 35-weeker 2.2 kg having respiratory distress, required CPAP for 24 hours. Currently, baby is 4 weeks. Should we do ROP? This baby is about 2 kg, about 34 weeks. Should we do ROP screening? Yes, you need to do ROP for late preterms if they have received oxygen or respiratory support beyond 6 hours. What is the ideal age to do Hammersmith neonatal neurological examination for such babies? What is the ideal age? Yeah, you can do it 36 weeks, but what is the ideal age for Hammersmith neonatal neurological examination? Not infant, at 40 weeks, right? What does Leicester scale assess? What does Leicester scale assess? Yeah, Dharni, Divya, it is correct. It's language. Name a screening tool to assess development. Name a screening tool to assess development. Yeah, Trivandrum Development Screening Test. You're right, Sagarika. DDSC, you're right, Divya. I think Patil, Anupam, Sagarika, you're all right. Sudarshan Bailey is a wrong answer. It's a diagnostic tool to assess development, not a screening tool. Sudarshan, okay. What does MCHAT scale assess? What does MCHAT scale assess? Yeah, most of you are right. It assesses autism. All right. Okay. 9th question. You have a 32-weeker 1.6 kg. In addition to routine care, your team decides to initiate KMC. What are the 3 components of KMC? Yeah, it's KMC feeding, KMC position, and KMC early discharge. I think Navdeep, Anushka have answered right, including Abdul, Sagarika as well. Okay. Name any 4 non-thermal benefits of KMC. Non-thermal benefits of KMC. Weight gain, right? Growth, yeah, weight gain, breastfeeding, child bonding, less apnea, cardiovascular stability, early discharge. Yeah, most of you answered right. What is the recommended duration of KMC per day as per WHO for quality outcomes? What is the recommended duration, or what do we call as quality KMC as per WHO? 18 to 24 is quite long, Navdeep. Abdul, 20 hours is quite long. WHO recommends minimum 8 hours to say quality KMC. 8 is the right answer. What should be the minimum duration of one session of KMC? I think Anushka, Divya, Mohammed, the right answer is 1 hour. At least 1 hour should be the minimum duration of one session of KMC. Ideally, we need to do as long as possible, but the minimum is 1 hour. Okay. Last question. You are planning to start a new NICU. Following are concerns raised by your new nurse. What is the advantage of using chlorhexidine in alcohol-based hand rub? What's the advantage of using chlorhexidine in alcohol-based hand rub? Clepsy prevention? No. We do not use alcohol-based hand rub for clepsy prevention. We also use chlorhexidine for skin preparation. Increase the killing time. Any better answer? Alcohol per se will prevent infection prevention. I think Ravi has answered right. Chlorhexidine will give you residual action. So apart from alcohol, chlorhexidine persists to have residual killing capacity, and also it has an emollient action. Okay, what should be the duration of scrub the hub before connecting syringe to IV line? 10 seconds is quite short, 30 seconds is quite long. I think Divya, Pradeep, Navdeep, Ritika, Mahesh, Karthik, you're all right answer. 15 seconds. 15 seconds should be the duration, and allow it to dry for 30 seconds. Allowing it to dry is also essential. Okay. Name any high-level disinfectant for floor cleaning. Name any high-level disinfectant for floor cleaning. Phenol is a intermediate level. Sporolol, I don't know what is sporolol. Bacillol is intermediate. Bacillol is intermediate. Yeah, it is. Any aldehyde-based solution or hypochlorite is a high-level disinfectant for floor cleaning. What solution should be avoided, or what solution is avoided while cleaning transparent surfaces? Yeah, we need to avoid alcohol because it can cause opacity and can form crevices and act as a bacterial reservoir. Okay. what type of precaution should be followed when you have a RSV infection in the NICU? Is it contact? Is it droplet? Yeah, it is both contact or droplet, ideally droplet precaution for RSV. Yeah. So I think most of you have answered this. I think that's it from me. So I think thank you everyone. All the best for your preparation for the exam upcoming. And for the new people who have joined, I think it's good to go through neurological examination. I think NNF had a class last week. Thank you everybody.